Hi everyone, this is Rosalind Liu. This is the School-Based Health Center Coordinators meeting. I just want to do a quick sound check. It's about 1 o'clock, so I'm going to wait a couple minutes to make sure that we get everyone on. But I want to make sure you can hear me. So if you can hear me, if you can raise your hand, so press your little hand button. Is there a hand button?
Yep.
Okay. So people are hearing me, which is great. So I'm going to put you back on mute for about 2 more minutes, and then we'll get started. Thanks. Good afternoon, everyone. I'm going to go ahead and get started. This is our spring School-Based Health Center Coordinators meeting. I'm Rosalind Liu. I'm the team lead for the School-Based Health Center State Program Office. Before we get started, I just have some logistics. Everyone's on mute. The webinar is being recorded and will be posted to our website hopefully in the next week or two. And once we get that posted, we'll send out the link to everyone so you can share it with any partners that may not have been able to make it today. We do have question breaks throughout the webinar today. So if you have questions at any point or during these break periods, you can type them into the check box or the question box, and we'll get through those questions as quickly as possible. If we can't get to those questions, we'll make sure we follow up with people or share it with the entire group if it seems relevant. Next slide. So this is our agenda for today. We have a lot to cover, and so we'll move through it pretty smoothly, hopefully. And we have some outside partners. So we have the state immunizations program coming. We have our partnership with mental health here at the Public Health Division, and then we have the Oregon School-Based Health Alliance, and then we have a bunch of data and policy updates from us at the State Program Office. So to start off, I'm going to turn it over to Jessica Duke, the manager for the Adolescent and School Health Unit.
Hi, everybody. I just wanted to give you a quick update on some staffing and budget here at the State Program Office. And so currently we're almost in the middle of the biennium. In June, we'll be in the middle of the biennium. And our budget for school-based health centers is stable. For those of you who are new to the school-based health center system, and as a reminder for those of you who have been around, our budget is mostly state general funds, so given to us by the legislature. And the money is earmarked for local public health authorities to give formula funds to certified school-based health centers in their counties. And it also provides funds to staff the State Program Office here. We have some limited OMMP, which is Oregon Medical Marijuana Program, funds from the OMMP fees, but those funds are not long-term. We've used those funds in the past to supplement the state funds that we have. We've used them to fund special projects over the years, but that's really not long-term sustainable funding. But we do have some of those funds. And then we have mental health expansion grant funds that come to us through the Oregon Health Authority Health Systems Division. So that's just a quick overview of our funding sources here. And again, most of our funding is earmarked to go to local public health authorities or county health departments to disperse formula funds for school-based health centers. And again, the take-home message here is that our budget is stable for the biennium. And then staffing. This is a picture of us on a Friday afternoon. We all went out and had pie. There's some school-based health center staff and also adolescent and school health staff in the picture. We are close to finalizing the hiring of our administrative support specialist position. For those of you who've been around for a while, you may remember Melanie Potter, who is in graduate school at UCLA getting her master's in public health. So it's been a while since Melanie left, and we've had the great help of Samantha in the interim. And Samantha's temp agreement is ending at the end of this month, and we're looking to bring on a new person, and we're close to finalizing that hire. So at that time, we will be staffed with the exception of the systems development specialist position, which we are required to hold vacant for the biennium. And that is it for budget and staffing, except for this piece of information.
Hi everyone, it's Rosalind again. I just wanted to briefly talk about a memo that was sent out a couple months back regarding the possibility of additional funding for any newly certified sites that were currently unfunded. So in order to be available to enter the funding formula for fiscal year 2019, which starts July 1, 2018, you would have to be certified before June 30th, 2018. And so we do know that, or we've been told that there are sites that will be closing at the end of this fiscal year, which does open spots for potential sites to come into the funding formula next fiscal year. So that being said, if we receive more applications than we have funding for, we will be prioritizing the funding to sites based on a priority list of criteria area, and they're listed on the slide. They were also in the memo. So at this point, we don't really know how many sites will be, exactly how many sites will be applying for certification. We don't have an exact number of how many sites may be closing by the end of this fiscal year. So really what will happen is we'll get to June 30th or close to June 30th, and then we'll look at our funding, and we'll look at what spots we have available, and then we'll look who we have that's certified unfunded, and then we will make a determination at that point on the funding piece. If you have questions about certification, if you have sites that you think might be ready to be certified, please reach out to our office. If you know who your public health nurse is, your certification nurse on our team is for your county, please reach out to them, Rebecca or Karen. You can also go to our website. Our website has the application to apply, the process and the steps that need to happen. I have to say that it is pretty late in the fiscal year right now if you're starting from scratch, but that doesn't mean that it can't be done. So if it's something you're thinking about or considering, please be in touch with us and go to our website as soon as possible, I'd have to say. So I just want to open it to any questions regarding the budget, the certification process, or the staffing. And again, you could type those questions into the question box. And if you have no questions at this time, you can write a question in later if something comes up, and we'll get to it. I'm just going to move us along. It looks like there's no questions. So policy updates. So the School-Based Health Center program is housed in the Adolescent and School Health Unit, part of Public Health Division, as you guys know. And we just finished our strategic planning for the Adolescent and School Health Unit. And I just want to remind people a little bit about the vision and mission and goals that drive the work that we do and some of the activities that you may hear us promoting and reaching out to you guys in the field about. So just quickly, the Adolescent and School Health Unit, this is our vision, that we believe that Oregon is the very best place for all youth to learn, grow, and thrive. And our mission is to support the health of all youth in Oregon through evidence-based practice, data-driven policies, practices, and programs. So these are the three goals for our entire Adolescent and School Health Unit. These goals, I'm not going to go through them, you can read them on the slide, but as I move forward through the activities that our School-Based Health Center program will be working on, you'll see them reflected in those activities. Just a reminder, the Adolescent and School Health unit or program is made up of, we have an Adolescent Health Policy and Assessment Specialist, Wes Rivers. You might have seen him presenting on the Oregon Healthy Teen Survey data. We have the School-Based Health Center program, and we have school nursing is housed in our unit, and a youth sexual health program. So this is the strategic plan specifically to our School-Based Health Center State Program Office. So let's get to my notes. So our first goal is to ensure that access points through improvement of our funding formula, so the base funding, planning, and the mental health capacity. So in the next year or two, is it the, oh, okay. Can you go to the next slide? I'm sorry. So the next year or two, we will be thinking about how do we develop a funding formula that really balances the expansion of school-based health centers across the state, the community need of new sites, which we know that there is, and the capacity of building our existing sites. So how do we support our existing sites through the base funding, the mental health funding, potentially other funding sources, but then how do we think about our budget and helping to expand, enhance the system across the state also? As some of you have experienced with us with the funding formula, we don't develop funding formulas without vetting it through or getting input from the field. So once we start this process, all of you will be fully engaged, and your input, of course, will be of value to the whole process. So our next goal is to give our school-based health centers the opportunity to learn from peers and clients to improve policy and practice. So what we're trying to achieve here is attempting to, a couple areas, is that we want to build in more youth voice to our training opportunities, to potentially our meetings, our conferences. We also want to give everyone the opportunity to learn from each other. You are the experts in what you do, and so create learning collaboratives on, specifically we've called out here finance and sustainability. And then really focus on the training and technical assistance around two clinical areas, in particular reproductive health and the integration of mental health, physical health, and oral health. As we know, mental health has expanded incredibly in the last couple of years for the school-based health centers, and we know that oral health is also growing. And we really want to support the school-based health centers to provide the best quality care. So these areas will be the areas that we hope to show quality improvement as we move forward in the next year. And the next one, next slide. And the last goal is to use existing data sources to enhance the assessment of our school-based health center services and the health needs of youth served by the school-based health centers. We will be analyzing the satisfaction survey data to assess the utility of the results. So we want to make the satisfaction survey results and improve them to make them more useful for us and for you. So we'll be taking a look at that. We'll also be providing school-based health centers with what we're calling mini adolescent snapshots to our encounter data and to the Oregon Healthy Teens data. So we've been really trying to increase our data capacity at our program level in order to be able to give data back to you guys, to be able to see what's happening across the state, to see what's happening in your school-based health centers, and then potentially identify areas of improvement. The next one is to analyze the OCHN EPIC health assessment data. And some of you may have been around long enough to know that years back, we partnered with OCHN EPIC and Multnomah County to create a student episode. And within that episode, there is a health assessment tool. And that data is collected by our office. People are not required to necessarily use the tool from our state program office, but we know that people are, and we really have not had the capacity to look at that health assessment data. So we plan to take a deeper dive into that in the next couple of years. And then the last activity is to look even further into our revenue and Medicaid billing and claims data. As you know, Sarah has been reaching out to the school-based health centers and really trying to get a handle on what's happening around the revenue and the billing and the claims. And we hope to be able to use that information to better support sustainable financial practices. And the last piece is, this is just a reminder to everyone that there's a lot I know that goes on at the local level, and there's a lot that's happening with us at the state program office, but to really remember that we are here as a resource for you all. So we definitely have the compliance component and want to assure that everyone is in compliance to meet standards, but we really are here to support you all to be successful. And we know that there are many competing priorities across public health, across health care, mental health, and please feel free to reach out to us as a resource, either to try to connect to other school-based health centers or to understand what might be best practice that are happening around certain pieces. We might not have the answer, but we can also help you find the answer. The other piece is that if you really feel like your center is struggling in an area that is a certification compliance issue, please reach out to us before crisis mode. I know there is always a concern, especially from new coordinators that might not have a relationship with our office, that if I bring it up, am I going to get penalized or in trouble at that point? And really, again, we are here to support you, and we would rather hear something earlier and work through it, as opposed to being reactionary to us getting on site and finding out later. So again, please feel free to reach out with us with questions, concerns, ideas, or if there's some sort of innovative, really interesting thing you're doing, we'd also love to hear that. Any questions about some of the activities that we'll be focusing on the next couple of years, or the program in general? Great. We will move forward. Okay, still me, still Rosalind. I will still talk at some point. Okay, I want to give everyone an update on where we are with the potential policy recommendation for contract agreements. So just to remind everyone, there was interest from local public health authorities to look at the possibility of having contracts between the state go to medical sponsors that are non-public health authorities. We put a survey out to all local public health administrators. We had responses from every county except for 3 or 4. And overall, it was very strong support for further exploration into this possibility. So those results were taken to the Conference of Local Health Officials Subcommittee, and they were also in support of us for further exploring this possibility. So at this point, we are convening a stakeholders work group, and hopefully everyone received the email from me requesting participation. Our goal is to come out with a policy recommendation regarding the SBHC funding processes and contracting. At this point, there is no policy recommendation. We are not saying that contracts should go to only LPHAs or go to non-LPHAs. We're opening up the stakeholders work group to really explore what are the possibilities of what this could look like, and really what are the implications if we were to go down this route. So if you are interested in being part of that stakeholders work group, feel free to shoot me an email. I think I asked people to get back to me by end of day tomorrow so I can start setting up the first work group date. I have had a lot of interest so far, and I have to say I appreciate everyone's engagement on this. I have local public health authorities that medically sponsor school-based health centers and don't. We have medical sponsors on the group. We have mental health represented. The one partner that I would love to get on the work group that I have not seen or heard from yet are school or school district partners. I know that the funding does not go necessarily to the school or school districts, but I do think that they are an important partner that could be impacted by the change in the power dynamic that could happen with the contracts. There are some communities that when the school district has struggled with medical sponsor relationships, they have used the relationship with the public health authority to help facilitate or mediate those discussions. And I think it's a little hard to change the dynamic of the way that school-based health centers may look, or the funding may occur without the voice of a school or school district. So if you know of a school district or school partner, please feel free to reach out to them and see if they'd be willing to sit on the stakeholders work group. The email was sent out to all the principals of the school-based health center schools. So the principals should not be completely surprised by a request if you were to go to them. But if it's passed today, that's fine. Next week, if someone's interested, please feel free to email me. It's a voice that I'd really like to get on the work group. So, any questions related to that, the contract agreements? Perfect. Okay, I'm gonna shift it over to the data team. Okay, here, you can sit here, please.
Hi, this is Kavita. I'm the research analyst with the Adolescent and School Health Program. I'll be presenting some of the health equity and disparities data. The Adolescent and School Health Program promotes health equity and focuses on youth that face barriers. So to achieve this, we have just started looking more closely into our data by race and ethnicity. So if you look at the first two graphs, the first one is the % of total visits by race and ethnicity, and the second one is the % of total clients. So what we're trying to present here is more like, if you look at the graphs, the Native Americans, which make up just 2.8% of a total client population and comprise of almost 3.6% of the visits, have the highest average visits for, that is 4.1 as compared to clients of other races. Next slide. For mental health, white non-Hispanics comprise of almost 65% of our population, as we saw on the previous slide, but 72% of the mental health visits were by white non-Hispanic clients. On the other side, the Hispanics are 27%, just 27% of our total population, but only 21% of the visits, of their visits were with a mental health provider. This slide just presents the insurance status by race and ethnicity, private and OHP. What I just wanted to get across through this slide was, as we see, the high % of white non-Hispanic clients had private insurance as compared to the other. So we have just started digging into this data, and we are going to look further into it with different buckets like reproductive health and well visits. So we'll keep you updated. Thank you.
Are there any questions? Go ahead and type them into the question box. All right, so this is Loretta. I just want to talk about the fact that there's a deadline coming up. I know it's not until October 1st, but it's coming, where you'll be needing to update the operational profile for each one of your sites. And what's comprised of that is the hours of operation, the types of services that are provided, the also important staff shift hours and contact information. And like you see here, S2HC, PCPCH status, if you've got a YAC, and all of that information is for the upcoming school year. So that's forward for 2018-19. Then I want to talk about two pieces of data that are for the previous year, which is 2017-18, and that includes the financial funding and revenue entry, as well as the KPM chart audit. Those are both for the previous year. We'll be doing a webinar training again in August, like we do. An email announcement will go out in July with a date, and there will also be an updated manual for the profile in case folks want to start entering things in before we do that August webinar. And you can feel free to contact our state program office email with any questions. And then some other data reminders. Your satisfaction surveys should be completed by June 30th of this year. I'm continuing to send out monthly reports letting folks know how many completed questions or how many completed surveys you've submitted. Our also important year-end encounter data is due by July 15th, and that'll cover visits that have happened since July 1st, 2017. For folks that have to send me the data through email, I'll be initiating secure emails in mid-June. If for some reason you need a secure email before that, just go ahead and email me directly. And then like I had mentioned, the KPM chart audit submission, that October 1st deadline. And there's going to be a slightly different process this year in the operational profile. Folks won't be able to go in and create a KPM entry until they have submitted to me their chart audit process and their audit tracking sheet. There's actually going to be a lock on that entry. So you have to submit those documents to me. I have to email you back if I have any questions, or I will let you know that everything you've submitted is fine, and I will unlock the operational profile for just that KPM entry. And that will be reviewed in August for the operational profile updates. But if you have any questions, again, if you have questions before August, before that webinar, feel free to contact me directly. If anybody has any questions, you can always email us. Okay.
Hi, everybody. This is Sarah Nipper. I just wanted to take a couple of minutes to alert you to a relatively new study that just came out in, I think it was January or February 2018 in the Journal of Preventive Medicine. I've presented before on a couple of other studies that the same group of researchers did in Oregon, where they were looking at our school-based health center data and our Oregon Healthy Teens data. They've done one study on access to reproductive health outcomes, and then this is their second study they've done specific to mental health services and the impact of the mental health expansion in 2013, which gave a lot of our centers, as you all know, more capacity. So, go ahead, next slide. So the study I presented on, maybe it was in January or last year, I can't remember. The first study that they did, they were looking at the impact of that increased mental health capacity on all students in schools with school-based health centers. And they found they had some really strong findings related to, you know, sort of pre and post expansion, that students in SBHC schools where there was expansion had, there seemed to be a much reduced rate of depression and suicidality among those students. So that was the 2017 study. This new study in 2018 looks at a very similar thing, but it's looking specifically at students who have identified mental health needs, and that comes from the Oregon Healthy Teens survey. So it's looking at students who have said, you know, they have experienced a depressive episode in the last year or had some other recent symptoms, looking at that group of students and comparing students with access to school-based health centers that had mental health expansion and those that didn't. And so they wanted to know, did their likelihood of suicidal ideation, suicide attempts, or substance use change pre-expansion to post-expansion? So this study included about 9,000 students with a self-identified mental health need. And this used the Oregon Healthy Teens surveyed data, 8th grade and 11th grade, in both 2013 and 2015. So within those 168 schools, there were 25 school-based health center schools. 14 of those had increased capacity due to the funding, and 11 did not. So what they found, similar to the first study, but when they look at youth that have mental health needs, so those in school-based health center mental health expansion schools, compared to all the other kids in the survey, were significantly less likely to report cigarette smoking, 23% less likely, 34% less likely to report suicidal ideation, and 29% less likely to report a suicide attempt. And then when they just looked at kids within school-based health center schools and compared the expansion to the non-expansion, they found a very similar finding just for suicidal ideation. There wasn't the same impact in substance use or suicide attempts, but they did find that difference in suicidal ideation. And so graphically, what this looks like, if you can see these two graphs here, so the first one on the left is suicidal ideation. And so this is just among school-based health center schools. And so the solid line is represents those students in schools with school-based health centers that had expansion. And the dotted line is the students in school-based health center schools that did not have expansion. And you can see the changes in suicidal ideation between 2013 and 2015. So there was actually a 34% drop in the expansion among kids in the expansion schools. And you can see that looks pretty dramatic. And then we see the similar thing for suicide attempts. So there was a 29% drop. And these are adjusted for both student and school demographic characteristics like gender and race, ethnicity, and I believe free and reduced lunch also. So, you know, there's a little bit of caution here because this is survey data. We cannot definitively say that it's causative. We can't say that expanding capacity in the school-based health center schools directly led to these changes. But I think it's pretty encouraging that controlling for these characteristics and pulling out those kids with access to increased capacity and looking particularly at the kids who have identified needs. I think these results are pretty encouraging, and they really show that, you know, what we're doing likely is having an impact, and so that's really nice to see. Any questions about that? And I'm happy to send the full study out too if folks are interested in seeing the whole thing.
So if you're interested, you can just send an email to the SBHC program email address, and Sarah will get that, and she can follow up with you. I'm going to turn it over to our state immunizations program.
Hi, this is Gabby. I'm with Vaccines for Children. So I just wanted to give you an update of what's new this year with Vaccines for Children. One of the new things is that we do have a newly updated vaccine management guide. This is the first page of it. So if your vaccine management guide still has Mount Hood on it, please make sure to take a look and look for the Crater Lake one. The nice changes about this one, it's got our new VFC help desk number right on the front page, which is great if you want to put the page over. The other part of it is inside we have an employee training plan. So basically this outlines all of the trainings that you should be taking as a vaccine coordinator and all the optional trainings that would be really useful. It's got the website link addresses for all of those. Okay. And next, there is the VFC task list. What this list does is it outlines the things that you should be doing on a daily, monthly, yearly, and every other year basis. So if you're ever confused, it's like, oh, should I take a training this year or next year? You can refer to this. This is also really useful if perhaps you have a manager who doesn't quite understand how time-intensive VFC can be. Showing them this list and like, this is all the stuff that I need to do is also really useful. The next part of the vaccine management plan that has changed is the emergency guide here. The biggest change for the emergency plan is the use of conditioned water bottles. So previously, the CDC had recommended the use of ice packs. That has changed. So if you ever do need to transport your vaccine, what they would like you to do is have water bottles that you just keep frozen. And if you need to transfer your vaccines, run those under hot water for a little bit until the ice can spread freely within the water bottle, and then use those to pack your vaccine. The purpose of that is twofold. First thing is we never want vaccine to touch anything that is frozen. So that ensures that doesn't occur. And the second part is those ice packs are not filled with water. They're filled with different material that freeze at a much lower temperature. So they're actually incredibly cold. So that is why the change occurred. The other thing that you'll see in the vaccine management plan, if you haven't already instituted in your clinic, is a change in how temperatures are taken. Previously, we would used to do 2 temps a day. That has changed. We're now doing a min-max once a day. You still do need to record the time that you took that temperature and the initials of the person who took it. The other things that we would like to make sure you guys are aware of and that you can participate in is AFIX. AFIX is really great. Basically what AFIX does is a health educator will come out to your clinic, and your clinic and your and if there's a clinician who might be interested can also participate. We bring data with us that gets pulled out of alert, and then we work with you to look at different strategies of increasing your immunization rates. Slide. And we give you feedback on performance and work with you on what strategies might work best for you. If you're interested, please call the VFC help desk or send them an email and let them know that's something you're interested in, and we could set something up for you. The next big update is vaccine stewardship accountability. So previously, anybody who was 95% and above accountable for their vaccines, got to be on the vaccine accounting excellence list that we send out to our listserv and post on our website. What we've done, though, is we've created a second tier. The second tier is also for vaccine accounting excellence, and it's for all of the clinics who are almost there to the gold, 85 to 95% accountable. So still the same kind of requirements, but to show that you guys are really putting a lot of effort, and it's not just the A+ students that should be recognized. So I think that's really excellent. So keep an eye out for that. Erin Corrigan is working on that list, and hopefully we'll see that soon with our next quarter. And then the last thing I just wanted to touch base on was flu pre-booking. If you haven't pre-booked yet, please do so. You can now do all of your pre-books through Alert. You just go there and there's a request flu button that you press, and that's where you request all of your flu. So no more Survey Monkey, so you just go ahead and do that. All right. That is it. Do you guys have any questions?
We do have one question. Is there a new temp logging sheet for min-max?
There is a new temp logging sheet for min-max. You can find it on our website. The easiest way to do that is Google for OHA VFC, and it'll just click on that first link. On the right-hand side, you'll see a link for forms and forms and publications, I think it's called. Click on that guy and you'll just scroll down until you'll find the min-max temp logs. You'll have your choice between Fahrenheit and Celsius. There will be one log for your refrigerator and another one for your freezer. Any other questions? Nothing else? All right, well, thank you so much.
Okay, we're gonna switch gears over to our mental health update.
Hi everyone, this is Kate O'Donnell, the School Mental Health Specialist with the State Program Office. Some grant updates for you all. So we have some reports coming up that will be due in July. So folks who have mental health expansion grants, we will have your quarter 2 report due July 15th, and those that have YAC grants, your reports for the 2017-2018 school year are also due on July 15th. We have not sent out templates for those yet. The YAC ones will probably be pretty similar to what you've received in the past. We may be making some changes to the mental health expansion grant ones, but stay tuned. I'll try and get those out to folks as soon as possible. I know the end of the school year is really busy, and some folks like to try and get them done before they head out for the summer. So stay tuned. I will be sending those out. And then just a reminder on funding. So as Jessica had mentioned, our funding is stable for this biennium as far as we know. Your unspent money from this current fiscal year will roll over into the next fiscal year, so fiscal year 19. The fiscal years run July 1st to June 30th, so anything that you haven't spent by June 30th will roll over. However, just keep in mind that all of your grant money must be expended by June 30th, 2019. So things do not roll over into the next biennium, so everything needs to be spent by that date. We do have some technical assistance, training and technical assistance opportunities specifically related to mental health to share. So some of you maybe were able to participate in the Columbia Suicide Severity Rating Scale Part 1 webinar that happened, I believe, in March. And then we also did a safety planning webinar that was held on Monday, April 30th. We have recordings of those available. The CSSRS one is available on our website right now. We're still waiting for a recording of the safety planning webinar, and we will have that posted on our website in the coming weeks. We are also going to be doing a Part 2 webinar for the CSSRS on August 8th from 7:30 to 9 a.m. So save the date for that. There was just a lot of interest in the first round, and folks wanted a little bit more information about how they could apply the tool in a clinical setting or a school setting, and so we're going to be working with Adam from the Columbia Lighthouse Project to bring that to you all in August. We're also planning on doing a phone summit for mental health providers. This is specifically for school-based mental health providers. Many of you all, or some of you may have participated in the in-person mental health summit last year, and the Alliance will be talking about an in-person one that they're planning for next year. But since there isn't anything planned this year, this is an opportunity for school-based mental health providers to just connect with each other around topics that may be of interest to them. In talking with folks on individual one-on-one calls, it seems like people are kind of hungry to hear what other sites are doing, kind of what struggles people have, what innovative ideas they have. And so this is an opportunity to do that. It will be a conference call. It will be kind of open Q&A, an opportunity for folks to connect with one another, and I'll be sending out more information about that as we get closer. And then just quickly, I'm working with the public health nurses, Rebecca and Karen, to plan check-in calls for the fall of 2018. And this would be bringing together folks on the primary care side, the mental health folks, and then dental folks to talk about holistically what things are looking like in their clinics. How can you integrate? How can you work together? What are you seeing? What issues are clients coming in with? What's your school saying? And trying to work together to see if there's any way that we can better support you, or if you have questions for us. So stay tuned for information about that. Will be coming soon. And then, as I mentioned, the Alliance is working to plan a school-based mental health summit that's in person in spring 2019. And I think Lori will be talking about that later. Is there a question? No. Okay, next slide. We hit the next button again. Ooh, some animation. Yeah. So finally, just wanted to share that the American Academy of Pediatrics recently updated its guidelines on adolescent depression. This is in a primary care setting. This is the first time these guidelines have been updated in 10 years. So for the first time, the guidelines have been updated to recommend annual universal depression screening for youth ages 12 and up. So this is pretty big deal. This is a shift, so not targeted screening, but really screening everyone who comes in the door to be screened for depression. Many of you actually probably already doing this to some degree with your health assessments, but these updated guidelines kind of provide some additional weight behind this, and also their guidelines really speak to some of the systems that need to be in place if you are doing universal depression screening. So that's kind of what's outlined on this slide. They stress the importance of laying the groundwork for this. So everything from providing staff training for depression screening, so different screening tools, assessment tools, what does treatment look like, and then how do you do a safety plan, how do you talk about consent and confidentiality with students, and then connecting with other resources in the community. So if someone does screen positive, what does it look like to do an assessment? What does it look like for them to plug into more intensive care for assistance with that? How does it look to link with the school? The AAP doesn't recommend a specific screening tool, but they do in their toolkit do reference the Columbia tool, so the CSSRS that we've done trainings on. So it's definitely something to look into if you're interested in that. They do recommend the use of a formal self-reporting screening tool, so either on paper or electronically, and give the provider, again, discretion to choose which one they think would be best. But they do recommend screening for suicidality at the same time that the patient is screened for depression, since not all suicidal patients exhibit symptoms of major depressive disorder. They also recommend a sample workflow is giving the student the screening tool before the provider comes in the room, and so giving the student an opportunity to do that by themselves and kind of not in a conversation with the provider. They also recommend identifying and monitoring youth with risk factors. So this is kind of their previous recommendation. So the targeted identification and monitoring of youth with a history of depression. And then, again, as you probably know, a positive screen, as well as any kind of informal indication of major depressive disorder, should prompt a fuller assessment. And so that would be a direct interview with a parent or with a patient and a family or other responsible adult. And again, provider discretion on what is appropriate here. The AAP does have some pretty specific recommendations about interviewing the adolescent alone and then being cognizant of the need for confidentiality, which I'm sure you all are very familiar with. And then I guess lastly, so I mentioned that they are pretty clear that any management that you do should include the development of a safety plan in case the depression escalates and the youth becomes suicidal. So this plan should be developed with the youth. And as I mentioned, we did do a webinar on safety planning just last week. So if you are interested in getting more information about this, you can check out the webinar for more information. Any questions?
Okay. Oh, wait, here we go. Here's a question. Are we going to get the guidelines from OHA or the SBHC program office? We do it annually through our health assessments.
We can send out a link to the guidelines. Yeah.
Great.
Awesome.
All right.
Megan.
Hi there, this is Megan Crane, Zero Suicide Program Coordinator for Oregon Health Authority, Public Health Division. So just have a little bit of time to check in with folks. Obviously, Kate already stole a little bit of my thunder, but that's fine. So I did want to take a little bit of time today, too, to just walk through a demo of the online training that we have for School-Based Health Center Cognito. So we'll do that in just a little bit, hopefully, if technology is working. So I did just want to first say, on the good news front, we've had a couple studies that have come out now showing that expansion of mental health in school-based health centers has shown a decrease in suicidal ideation and suicide attempts. The most recent study, which did kind of a deeper dive, showed that among youth who reported a depressive episode in the past year, those in school-based health centers, schools with increased mental health capacity versus all other schools, were 34% less likely to report suicidal ideation and 29% less likely to report a suicide attempt. Oh, Sarah talked about this already. Look at that. I was just so excited. So reminding you guys again, whenever I can share good news, I am excited to do that. And I'm sure Sarah did it much more eloquently than I did. So, all right, moving on. So again, just want to remind folks of kind of what the picture of suicide looks like. I know that school-based health centers were primarily focused on adolescents and youth, but I always want to make sure that we're not forgetting about looking at, who's dying by suicide in Oregon, and remembering that if tomorrow we could eliminate youth suicide in the state, which of course would be fantastic, we'd be eliminating just around 100 deaths, meaning that we'd be close to still having 700 deaths in the state that we need to address, looking at our older populations in particular. And also, this is just a reminder of a chart here that we have these data dashboards on the Oregon Health Authority website. Many of these data points you can pull by county. So again, just something you can use when you're trying to get a better idea of what suicide looks like in your community. Next slide. We in Oregon do see a higher rate of suicide overall among youth than in the country, although there is an uptick across the country. So again, I think here we're just trying to figure out other ways that the states can support counties and school-based health centers in this work. The webinars being one small example of how we're trying to do that work, but we certainly recognize that this is something that communities are feeling more and more burdened by, and trying to figure out appropriate ways that we can support that work. And also as a reminder that more students think about suicide rather than attempt suicide. And this is just a reminder that we need to figure out how to identify and support those students, some of which we may never see in a healthcare center, even those who have attempted, some that may take a medication, for example, and wake up and not have told anyone about their attempt. And so it's not just about making sure that we prevent students from attempting suicide. It's really supporting students that are having thoughts of suicide in a place where they don't belong, or considering this, that hope and recovery is possible, and that these are the messages we really need to be promoting. Next slide. Again, just a different way to look at the percentage of suicides by age group across our state, and keeping that in mind in our work. Next slide. So again, I've talked about, you guys are probably maybe a little sick of me talking about the Cognito at Risk for Primary Care program, but really is a short way that folks can practice motivational interviewing in the sense of behavioral health. I've talked about it a lot, but I figured we could do a quick demo of the program to kind of help, if you haven't done that, that you could kind of see what it actually looks like. Yeah, it has to be through the next slide. Oh, no. But it can't be through Internet Explorer or. Oh.
I think we have it open.
Oh, great.
I don't know what we have. It might be open through Internet Explorer. I think you're going to have to.
Yeah. Yeah, it does.
Bear with us.
Come on. Trying to get it. Let me just open. Sorry. Let me just open it back up and it's here, and then I'll copy.
It won't run in Internet Explorer?
It won't.
Here or anyone?
Anywhere.
Like, well, that's good for people to know. Don't open Internet Explorer. It opens on the login page.
This is different though, because this is a demo of the program.
Oh,
so
okay.
You can you can log in.
So if people are using it, it would work on Internet, or
It
no?
doesn't have Firefox.
Okay. Well, that's no problem. Again, I'll send out the demo link. That's fine. Either you can take the full program or take the demo link. The demo is just a short way to look at it. For example, if coordinators or directors wanted to take the demo to see if it was something they thought was applicable to staff or help determine what staff it could be applicable for, it's just a shorter way to see that. So, but again, the program is entirely free. It was developed with primary care professionals. There is some CME that can be attached with it. Really, you can see in the picture there, you have the adolescent and the healthcare provider. And what's great about it is you're going to be prompted to pick different questions or scenarios. So if the adolescent says, like my stomach's just really bothering me, and you kind of, in the start of the scenario, is saying, we've gone through kind of a physical health check and, we haven't found anything. Sometimes stress might cause, sometimes I see with you know, people like you, that stress can sometimes cause these physical, you know, feelings. And then the youth might say, oh, really? What does that look like? And then, you know, you might ask a question like, what's been going on at school? And this youth talks about, I tried out for, this is a new school, you know, I tried out for the lacrosse team and I made JV, and I'm really bummed out about that because of my old school, I was like a starter, and so I'm just not really finding my place. And so you're seeing maybe this kind of loss of belongingness or not finding their friend group, and so talking them through that. You can also see the reaction of the youth to how the conversation is going. So for example, if you were to say something like, I know that not making, you know, that making the JV team seems like a big deal right now, but when you're an adult, it won't. The youth thought bubble is probably going to say something along the lines of like, well, maybe it's not a big deal to you, but it is to me, and therefore you don't really know what you're talking about or can't relate to me in any way. You also have a little helper at the bottom that's going to pop up and say, you know, maybe there's a better way to solicit a response from this student, or a great job on kind of asking in that way, and that's going to solicit a response and continue this conversation on. So if you go to the next slide. So this is where you can access the programs. Again, you do have to create a login, but it is free. All school-based health centers should be in the drop-down menu already. If for some reason you don't see yours, please let me know. It's just a question of getting it added in. Next slide. This is what you'll have to enter in when you create your login. Just choose the primary care professional POV or point of view. And then next slide, you'll be asked to just enter a little more information, including what your role is, if you work as a mental health provider, and then a way to get credit if you would like that. Next slide. So I just wanted to point out a couple things. So looking at risk factors associated with adolescent suicide, I really just wanted to, I highlighted relationship problems, really just recognizing that especially for boys, we're seeing this as a risk factor in many suicides. So really just something to keep in mind if a male student is presenting with and talks about loss of a relationship. Again, not every male student that loses their relationship, you know, is going to attempt suicide, but just something to really look out for. Also, the recent or imminent crisis. So again, what we're really identifying here is periods of transition. So was there a suspension or even just kind of altercation at school, some touching the juvenile justice system, or has bullying been a recent factor? So really just, I wanted to share some circumstances just so folks can keep that in the back of their mind when they may be talking to youth, and just point out those two that we've really been seeing in national trends as well. And then next slide, also just not trying to give you too much information, but if there's one thing, you know, you're gonna take back to your school-based health center today is that for any student you identify at crisis, really just making sure that you're thinking about lethal means counseling or particularly firearm safety. When we identify a student at risk, we really want to talk to them about what their plan was, and if they had a means in place or were thinking about a means, how can we talk about to them or their family about removing those means for the period of crisis. And really seeing that this impulsivity or reaction has really seen that people attempt within, you know, 5 minutes, 5 to 19 minutes, under an hour for the majority of people that have attempted suicide. So if we can put some time and distance between them and the bottle of pills, or between them and the firearm, or between them and, you know, the hanging or suffocation mechanism they were thinking about using, we can potentially save a life. There's counseling on access to lethal means. I'll send out the link as well as a free online training, which is a fantastic training for lethal means counseling and something that you can use. And then it was also discussed in the safety planning webinar that was just held. We are holding the Zero Suicide Academy here in Oregon. That's for healthcare organizations. It's really quality improvement project around suicide safer care, with national experts coming to support those efforts. I think school-based health centers could definitely apply for this opportunity, whether you're connected with a larger healthcare organization or not. I'm happy to talk through that opportunity more and if it applies to your organization. And we're also doing a community of practice for better suicide care into the fall and winter. That is another opportunity people can be aware of. I believe Kate already talked about these. So again, we have the safety planning webinar that we just completed, and then the initial Columbia Suicide Severity Rating Scale. Also, the beginning of that webinar is just some kind of basic suicide prevention intervention training, which I think anyone can find useful. And then we're following up with kind of a deeper dive into the Columbia on identification and triage and how you would use that tool in different circumstances, coming up in August. And then finally, just a reminder of resources. The Youth Line is a fantastic resource, especially when we think about safety planning, making sure that every youth that you think may be at risk or just is having a bad day leaves with this text or phone number. Another thing that I think can reduce barriers, whether you're promoting the Youth Line or the National Suicide Prevention Lifeline or your county crisis line or internal healthcare line, is calling that number with the teen. I think that breaks down a lot of barriers. People you give them a phone number and they're like, what is going to happen when I call this phone number? So just sit in the room and call them. I call the National Suicide Prevention Lifeline all the time. And I just identify myself, hey, I'm here with someone that may, give you a call in the future. And they just wanted to know, what are you going to ask for when you call this number? And what is that conversation going to look like? So again, the Youth Line is a fantastic resource. 4 p.m. to 10 p.m. Peers are answering the phones, of course, supervised, or answering those texts. If it's not between that time period, adults will be responding. So again, I like that the Youth Line isn't called a crisis line, because we really want youth and anyone to be contacting these lines before they get in crisis. So if you're having a bad day, the Youth Line is there to talk to and say, oh, I'm so mad at my mom right now, or, school was just so hard today. There's a peer on the text or the line that can talk to you about that. It doesn't have to be a crisis. And then below here are just some resources that I've talked about today in the presentation. Means matter. I'll just highlight the second to last bullet point there is really focused on that lethal means piece, which I highlighted. Just really goes into the research behind that if you want more information on that, or of course you can always contact me. Happy to take any questions if there are any.
I have a question, Megan. This is Rosalind. I was just at a conference and there was a OHSU doctor that was talking about how their clinic, when a young person is identified at risk, they work with the parents and they actually give them medication lockboxes. Mm-hmm. Have you heard of other clinics doing that? Is that something?
Yeah, I think a lot more organizations are trying to do that, both for medication lockboxes as well as for firearms. So I've heard of a lot of organizations that have gun locks for folks. So usually they're not the quote unquote nice ones that gun owners really want. What gun owners really want are like the biometric ones where you actually have to put your fingerprints on it to release it, because those can release very quickly. And for those that say that they need a firearm for protection, then you can kind of bypass it can't be locked, the ammunition needs to be separated, and I'm not going to be able to get to that when the burglar breaks into my house, and it takes me 10 minutes to get to the gun. So OHSU, had some funding that they were able, and so the medication pouches they have are fantastic, and they're able to offer them at cost. So I think more and more places are trying to see how can we not just have that conversation with someone in the office, but say, here is the tool that can really help you to as soon as you get home, you can eliminate or dramatically reduce that risk.
Yeah, and it seemed like there was this, there's this perceived barrier of that I have to go and order it, and then there's so many types out there, and then we type, and so it seemed much easier to be like, as a doctor, or your provider, here is what we're giving you, take it, put it, it could.
I think it's a great example of what healthcare can do to just reduce another barrier, right? And cost as well. So it's not just, great, I ordered this thing, which I'll get in 2 weeks, but I'm supposed to take care of this issue
and
right now.
And you're telling me right now that this is a concern and I can do something about it right now.
Yeah.
So I thought that was interesting.
All right.
Questions? Thanks, everyone. Thank you, Megan.
Thank you.
So we're gonna, again, shift gears. We shift gears really quickly around here. We're gonna give youth sexual health updates. So Rebecca Jacobs, our nurse. You can introduce yourself again.
Hi, this is Rebecca. I'm one of the public health nurses here, and I'm going to talk about chlamydia and gonorrhea. Because of the rising STI rates in Oregon, we thought it would be important to talk about how SBHCs play an important role in preventing, screening, and treating STIs. So we know that STIs are at record high rates across the nation and Oregon. And because of this, the CDC sent out an urgent message asking everyone to step up prevention. So for the purposes of this presentation, we're only going to focus on chlamydia and gonorrhea, but there are other STIs like syphilis, HIV, that can be screened for in SBHCs as well. And I'm going to cover these things on the slide. Next slide. So this is the Oregon chlamydia cases from 1988 through 2017. And I think, as you can see, since 2002, it's been on a steady climb upward. Next slide. And this is a slide of chlamydia rates in Oregon for teens from 2012 to 2016. Adolescents 15 to 19 years old, broken down by male, female. The rates of many sexually transmitted infections are highest among adolescents and young adults. And the reasons for that are, or include, some of the following factors. Having multiple sexual partners at the same time, having sex partners one right after the other with limited duration relationships, failing to use barrier protection consistently and correctly, and having increased biologic susceptibility to infection. And that has to do with certain cells in the cervix or on the cervix. And also facing obstacles to accessing healthcare. Next slide. So this is a CCO metric for chlamydia screening, and it shows the percent of sexually active women ages 16 through 24 who had a test for chlamydia in the years 2015-2016. The gray line on the right is the benchmark for screening at 64%. And as you can see, no CCO is meeting benchmark. Lots of improvement to be had there. These are the Oregon cases of gonorrhea from 1967 to 2017. It shows that, or at least it shows to me, that it seemed well in control for about 20 years, and then it's on the rise again. I know. We can't see the whole screen here, but hopefully you guys can. And these are the gonorrhea by age and sex in 2017, broken down again, female and male. And 18 to 19 and 20 to 24 years old, you can see, are some of the highest. So when talking about STIs in Oregon, it's important to note that there's a real problem in the education. And this is a survey, the School Health Profiles Lead Health Educator survey in 2016. And 79% of schools are talking about HIV and STIs. This is middle school. And only around 50% or less are actually talking about condom use, which we know would be important to prevent STIs. Next slide. This is high school, so doing a better job, but still falling below talking about how STIs are transmitted, is still higher than teaching condom use. And interestingly, on both slides, how to correctly use a condom was the lowest percent. So youth coming into your clinics may not be aware of how to prevent the STI. All right. I gotta turn my page. So this is a map of the regions created by counties to work together on communicable disease control programs with funding from the Oregon Health Authority in 2017 for modernization. 4 regions are working specifically on prevention of sexually transmitted infections. And in those 4 regions, school-based health centers are an important access point for partners to work to prevent disease. If you have any questions about modernization, there was a link there on that slide. Okay. So this slide shows the highlighted counties there in those regions we talked about on the other slide, and their concurrent SBHCs, and then what they're working on specifically as part of their modernization. Next slide. And these are also counties within the region and their school-based health centers, and then what they're working on this slide. That's okay. So we encourage school-based health centers to partner with this regional work to reduce sexually transmitted infections. One of the ways to measure the modernization work is to look at gonorrhea rates in Oregon. This shows the gonorrhea rate in 2016 by county for all ages. Benchmark is set for below 72 per 100,000 incidence rate, and the darker pink is the better gonorrhea rate. There are 13 counties that do not meet benchmark here. Next slide. And this is the same data broken down by race. And there's that 72 benchmark. Okay. These are the school-based health centers currently in the 2017-2019 biennium with the optional KPM of working to improve chlamydia screening. There's lots there. So, chlamydia, gonorrhea screening recommendations. In February, the state published a report called The Rising Tide of Sexually Transmitted Infections in Oregon. And there's the link. The report outlines who should be tested in Oregon, and these recommendations differ slightly from the CDC screening recommendations, either to simplify or as a consequence of ongoing epidemics in Oregon. So who should SBHCs be screening? Women less than 25 years of age, at least annually, if sexually active, and I would add, with any new partner as well. Young men, if increased individual risk or high prevalence setting, at least annually, if sexually active. Adolescent clinics were specifically called out in this report as a high prevalence setting. So all SBHCs should be testing young men at least annually if sexually active. And in addition, anyone with a positive test should be retested within 3 months because rates of reinfection are pretty common. And there's also screening for the oropharynx and rectal testing as well if needed. Okay. So this is essentially a call to action for SBHCs. The call to action is, in the report, discuss 3 areas. The first is getting a sexual history. Providers should make a habit of taking a sexual history from everyone aged 13 or over, including whether they are sexually active, frequency of sex, number of partners, and gender of partners. And then it's screen and treat. And then expedited partner therapy is the antibiotics that you can give to the partners of patients who are diagnosed with gonorrhea and chlamydia. It's not only legal in Oregon, but it's encouraged by the Oregon Public Health Division and by the CDC, where partners are unlikely to seek evaluation, testing, and treatment. And randomized trials have demonstrated that EPT prevents recurrent infections. So SBHCs are a great place to screen and treat chlamydia and gonorrhea. 15 to 24-year-olds account for half of all new STDs. So I'm used to saying STI, but we still have the STD program here, so that's back and forth, but there you go. So again, adolescent clinics are specifically called out as a high prevalence setting, so SBHCs can help stop the trend by asking questions, screening, and treating.
Any questions for Rebecca? Nope, we're going to move forward. So just, I wanted to show everyone a new resource. So essentially a new youth sexual health resource. It's the Oregon Sexual Violence Resource Map. It's a mapping tool that was created to look at risk factors, protective factors, and outcomes related to sexual violence, sexual health education, and it particularly highlights adolescents. So it can be used to identify risk and protective factors in your community, to understand the difference that are happening in communities, and to look at trends over time. So it is a very cool tool. I'm going to open up for you guys to see. So it's done in partnership. So the Injury and Violence Prevention Program worked on this. And what you can do is you have a toolbar on the left side. And so I'm just going to scroll down. And there are these topics. So we can look at, let's look at sexual coercion among Oregon teens, 11th grade. So this talks about, let's see if I can scroll up a little bit. So it talks a little bit about the data source. So this is pulled from the Oregon Healthy Teen Survey. It gives you some cautions around how you're interpreting the data. And it gives the website of where you can find it. And then when you actually go to the map, here, let's pull, no, not that close. I can't see. So, and there's a legend off to the side, and it tells you the different rates and what the colors mean. So you can get a really quick snapshot of what's happening and where does your county compare to other counties in the state. And then let's go down to what else. So they have sexual behavior among 8th and 11th graders, again, pulled from the Oregon Healthy Teens data. Quick snapshot of the map. So if we zoom in, you can zoom in onto a specific county. So you can choose any county. So Wasco County, it gives the 2017. So I encourage people to just go, and then you can get the chlamydia rates by male, female, and you can zoom in more on the numbers. So so again, it tells county, it tells the numbers, and it gives the rate. So I think it's a really cool tool. I think they're still fine-tuning it, but it's an amazing resource for people that are doing this work, or you are reporting out on the need, or trying to get resources into your community. So I'd say go and try to play around with that a little bit. Okay, let me take you back to the PowerPoint. That's the mapping tool. And then I just wanted to remind people of, there are some youth sexual health webinars that are happening. They're coming out of the Transformation Center in partnership with the Sheila Johnson, the coordinator of the youth sexual health program here. And we sent out an email with the whole list of them, and there are 3 left. Tomorrow's webinar is specific to reducing STIs and what's going on. And they're every 2 weeks, so the one after that will be sexual health promotion and sexual violence prevention. And I've given the dates and the links. You can also go to the Transformation Center and look under, I think it's under CCO resources, and it talks about it's specific to supporting the effective contraception measure, and the webinar information is under there. And then the final one is focused on health equity and youth sexual health. I think that's the last one, yeah. And I would encourage people, if you have the time, to go in and whether it's attend the webinar live or go back and listen to them. Sheila has invited guests appropriate to the topic for each of the webinars, and they're really fabulous. I think they really give a perspective that's outside of the typical clinical box to youth sexual health, and so I really encourage you to share it with your providers and your partners. So, questions? Someone asked if the webinars are available later, and yes, they are. So they are recorded, and then they are posted on the Transformation Center page. I will send that out. Loretta, can you make a note for me to remind me? I'll send out the link to where the recordings are, so you can go back and even hear the ones that have already been done. And they've been getting really great attendance and really great feedback. So again, I encourage people to attend them if you have the time, or listen to them later. Okay. No other questions. So I'm going to turn it over to the Oregon School-Based Health Alliance.
Good afternoon, everyone. I'm Lori with the Oregon School-Based Health Alliance, here with Ashley, and I think Maureen's going to join us by phone or attempt to do so.
Let's see.
So hang on just a moment and we'll see if she's on.
Okay. Maureen, you're unmuted.
Hi.
If you want to.
Great. Can you hear me?
Thank you. Yes,
Great. Hello, everyone. This is Maureen.
Okay, go to the next. So just a little bit about us. Of course, we're the nonprofit organization that strives to create an environment where all young people are healthy, learning, and thriving. And our mission has not changed. In the next slide, nor has our guiding principles. So we're about sustaining, strengthening, and expanding school-based health centers, promoting diversity and equity that engages both community and youth voices, and advocating for and facilitating the integration of health, wellness, and education. Our current staff includes myself, Ashley, Maureen, Jessica Chambers, and Gabrielle. And Maureen's going to give us a legislative and policy update.
Hi, we had our School Health Advocacy Day, as many of you know because you came, and it was fantastic. That happened in February. We had over 150 kids there. It is always a pleasure to put that on, and so we are already planning for Advocacy Day for next year, which will also be in February, and we'll send out a save the date soon. And if anyone has feedback ever, I mean, I know we do evaluations, but if anyone ever has feedback, please feel free to send it to us as we start planning really early every year for this. So this session was a short session. It was just a little over a month long, and so we didn't do a whole flurry of bills or anything. What we did was ask for a budget increase for school-based mental health, and we were able to have that be awarded. It was just under $1 million, and that funding is likely to just go to schools that do not have school-based health centers, since school-based health centers are already receiving the school-based mental health fund. And that's all I know about that right now. And if we have more information about how schools without SBHCs can access that, then we can also let you know that. You can go ahead and go to the next slide.
So this is Ashley McAllister. I'm the program manager with the Oregon School-Based Health Alliance. I will be providing some information on youth advocate updates. So there are 2 youth leadership programs within our organization. One is the Student Health Advocates and the other is the Statewide Youth Action Council. And these groups were both really involved in this year's School Health Advocacy Day. And it gave them the opportunity to meet with their legislators to advocate for school-based health centers. And they were joined, like Maureen said, by more than 150 students this year. So I just wanted to take a moment to thank all of you who do the work to bring youth to this annual event. And as Maureen said, we will be sending out a save the date. We don't have it included in the slides, but we just booked it for Wednesday, February 28th. So if you have a pen handy, you can write that down. And our student health advocates have also been involved in advocating for the National SBHC Authorization Act. And we continue to explore other opportunities for them to be involved with policy and advocacy work. Student health advocates have also recently presented at trainings and conferences, including the YAC training for mental health YAC grantees. Just this last Saturday, they spoke at the Oregon Pediatric Society's annual conference. This year's focus was on adolescent health, and they were on 2 panels. And they will be speaking on a panel at the HPV statewide summit on Thursday, May 31st. Applications for the student health advocates for the 2018-2019 year will open on September 10th. And this is an opportunity for young people in the Portland metro area to engage with our work for a year. Next slide. We also just wanted to provide a brief update on the highlights of the SBHC development work with Gresham and Reynolds school districts. So we have been working with both school districts to develop business plans for future school-based health centers, and both districts are continuing to move towards opening school-based health centers. And through the community engagement that we've done with parents and students and community organizations, we have heard over and over again that mental health services are priorities for communities in both school districts. Next slide. And I also want to provide a brief update on our Healthy Teen Relationship Act implementation project. So we are working to create a model for implementation of the Healthy Teen Relationship Act at 2 Portland high schools, Cleveland and Franklin. And HTRA requires that schools adopt policies and programs addressing teen dating violence. It passed in January of 2013, as many of you remember, but there was no funding attached to the bill. And there are currently no public schools in Oregon that meet the full HTRA requirements. So we are trying to change that. And our project aims to expand and broaden and deepen healthy relationship education, prevention, and advocacy services for students with the goal of creating a school-wide culture of consent. And this spring, we received superintendent approval to provide on-site confidential healthy relationship advocacy to students at both Franklin and Cleveland High School. So this is unprecedented. It's currently the only public school approved program offering on-site confidential services with non-mandated reporters. So we're working with partners at Raphael House and VOA Home Free, who both have advocates working in the schools, and we're working closely with Portland Public Schools and both high schools and their SBHCs to implement this. So we look forward to continuing this work towards building a model for implementation, and we hope to create a model that can be replicated at other schools across the state in the future. Next slide.
So we've talked about the trauma-informed schools work before at Tigard High School and Central High School. So won't really go into that. We're finishing up our second year. What we've really done this year is, sorry about that. What we've really done this year is worked on creating a deep and strong structure and system for doing the work. And we feel pretty good about what we've accomplished there. We're creating domains, goals, objectives, and full-on work plans for the rest of the pilot. And next year, we're focusing even more deeply on just continuing the implementation, looking at policies in the schools, and really trying to focus a lot more on family and student engagement and community partner engagement as well. So we'll be taking a look, especially the most in Central High School, at can we pull together a collaboration of community partners that provide health and other kinds of support services for students to develop more intermediate interventions for students who may not need to have individualized counseling, but who maybe need some extra support before they get to, more of a crisis point. So we're really trying to work on setting up trauma-informed systems at sort of multiple levels of need and intervention. Next slide.
So we also continue work with the Lane County SBHC Community Collaborative, which is funded by Kaiser Permanente. And we've talked about this before, and just want to give you an update and let you know that we have established our work groups. We have 4 different work groups. That may be on the next slide, I'm not quite sure. We have had regular convenings at different levels. So both among the work groups, doing focused work in areas that include mental health and culturally specific care, as 2 examples. And then we get together as a larger collaborative to provide a deeper dive into continuing education, needs and wants, and then also it provides an opportunity for the work groups to collaborate more. So we're real excited about how we're moving forward with the work itself, and then are also developing some branding that can reflect the collaborative itself and the work that it does. And we're thinking that it'll be really helpful to better inform the community, parents and the broader community, about availability of school-based health services and what a great difference they can make for prevention and needed services for youth and others.
So through our contract with the State Program Office, we provide ongoing technical assistance to the SBHC field, and I will be speaking first about opportunities related to youth engagement. So we recently provided 2 webinars to the field, one on an introduction to youth-adult partnerships and one on creating engaging and powerful YAC projects. And we also provided youth-adult partnerships and youth participatory action research trainings for SBO's YAC grantees. And next up, we will be hosting a regional SBHC, CCO, LPHA meeting on partnership opportunities related to youth engagement. So that'll be taking place this July for Coos, Curry, and Douglas counties. And we will have 2 additional regional meetings taking place next year, along with a Youth Action Council Summit that we'll be planning for the spring of 2019.
And this is Maureen again. I'm going to talk about the Alternative Payment Innovation Project. That project's been going on for a couple of years, where we've been really looking into how to how we can maybe develop or explore alternative ways of SBHCs being paid by CCOs. And the project is wrapping up. The project itself is wrapping up, but I think some interesting things have come about as we've been moving towards wrapping up. A couple of things to keep an eye on is really, there are a lot of conversations right now about what people are calling CCO 2.0. And I think that it would behoove all of us to really pay attention to those conversations. There's a lot of talk about CCOs working on addressing social determinants of health. And we think that, of course, school-based health centers are really in a unique position to do that. And so being able to talk about that and share the value of SBHCs as CCO 2.0 is developing, I think is really important. So where the project is now is that Multnomah County and Care Oregon are looking more deeply at exploring further payments, exploring possibly expanding the eligibility of school-based health centers in some of their payment models that they have, and then exploring a little bit further if there are areas where the school-based health centers are providing services where they're not getting reimbursed. So that work is going to continue, although the official sort of state contract piece of it that involved the School-Based Health Alliance will end. I don't think the work will discontinue. So I imagine at some point in the future we'll have a little bit more information to share about the outcome of that. Next slide.
And as Kate mentioned earlier, we are working on planning for a mental health summit that will be next spring, 2019, probably in April. And so we've convened a very enthusiastic and wonderful planning committee, and we're meeting both in person and via conference call about every 6 weeks. And so recently, a field assessment survey went out, and hopefully everybody got it. And we are beginning to collect and pull together the results, summarizing those, and bringing them to the next committee meeting to help inform what the focus will be and what the summit will look like. So we'll keep you updated as we move on, and we will be sending, once we determine the date of the summit, the one-day summit, we'll be sending the date out and more information. And this is our contact information, and we're open to any questions that you may have.
So we had one comment, mostly Maureen and maybe Sarah, around the APIP work was it looks like, I'll fill in some words here, but it looks like, are you looking at RN visits, the 99211 code on APIP, health assistance and other SBHC providers? There's a huge amount of work. So I don't know if you want to speak to that. You're going to have to come over here if you're going to speak to that, or Maureen wants to speak to that.
Do you want to go ahead, Sarah?
Oh, a huge amount of work around the health assessment.
Yeah, this is Sarah. I mean, I
doesn't get covered.
I can start. Maureen, you can jump in. Yeah, we have recently started talking more explicitly about this issue, specifically as it relates to RNs, recognizing that there is, as you said, a huge amount of work that's happening in the SBHC that is not being billed out. So we are talking about that explicitly. I think I'm really encouraged by the most recent nature of our conversations with Care Oregon around, not specific to a type of provider necessarily, or a specific code or a specific service, but more to thinking about all of the ways in which school-based health centers are supporting the kinds of metrics and outcomes that the CCOs are looking for, like the well visit, like ECU, like depression screenings, and recognizing a little more explicitly what goes into that is all of these other services that and staffing models that can't be billed. And so I feel like we're finally getting some traction on that conversation. And I think part of, I mean, Maureen, please, you might have a different perspective on this, but I think part of the challenge is that CCOs have been pulled in a lot of different directions, and they've been forced to really prioritize beyond the very standard metrics that they're responsible, beyond those reporting pieces. They've been forced to really prioritize populations or types of care that they're interested in, and I think adolescents, especially honestly, I mean, adolescents were really a focus and transition age youth were a focus at family care, and family care is no longer. And I think we are starting to have a conversation about, okay, well, who's going to kind of take up the mantle here? But yes, we are talking about those things, and I feel more encouraged than I have been in a while that we have potential to make some movement on taking those into account as we're looking at payment and reimbursement. Maureen, do you have other things to add to that?
Just to mention that Care Oregon is in partnership or in control of 4 different CCOs across the state. So it's not, while this may be a Portland Metro effort, if we're able to make headway, I think it's something that we could really sort of as a field embrace more with other Care Oregon CCOs and then potentially with non-Care Oregon CCOs. So those 4 are Health Share of Oregon, Jackson Care Connect, Columbia Pacific CCO, and Yamhill Community Care. So I just wanted to mention that.
Yeah, that's really a great point. Thanks.
Thank you. So if you, someone, is Care Oregon part of All Care? Question. No. Care Oregon is not part of All Care. So we are a little early. I just want to give people the opportunity to type any questions that you may had from any of the presentations today. And as a reminder, the PowerPoint will be saved to our website, and we'll send that out. We are still planning for an in-person October coordinators meeting. We do not have the date set yet. We're exploring what that would look like and the possibility of not, if we have the funding, not having to do it in the Portland State Office building because we know how tight that space is. Last year we didn't have that option, but we may this year be able to go somewhere else. We have heard the feedback from people that the dates, that October is not always the best. As a team, we're talking about how to meet everyone's needs and the timing, but also understanding that fall seems to be a really important time to kind of start off the year for everyone. So we'll talk about it more and possibly may survey you all to figure out the best timing and topics as we move forward. There does not seem to be any other questions. So again, I just want to remind people to please reach out to us if anything comes up. You can always send an email to the State Program Office email address if you don't know specifically who to ask, and it goes to all of us. Otherwise, thank you everyone, and hopefully it's sunny where everyone is. We're in a no window building in a room. We have one question. When will this be available on site? So we will post it probably within the next 2 weeks, and you'll receive an email when the PowerPoint is posted. Great. Thank you, everyone. Bye. Bye. Bye.